Welcome back to the Health Bridge. Dr. Pedram Shojai, sitting here with one of my favorite people in the world. I call him Uncle Ben, Dr. Ben Rubin, who was one of the first physicians I met when I moved down to Southern California, more Southern California from LA. He's an orthopedic surgeon, one of the top brass in our industry. He has been a team doctor for the U.S. Olympic diving. He was a clinical professor at UC Irvine. He has been around the block, and he's one of the who's who in sports medicine. And I met him in an acupuncture session because he's like, well, what is it that you do? And it was one of the most genuine, pure moments to have this like top brass orthopedic surgeon come in and say, listen, I'm open. I'm a true scientist, really, because I'm open to whatever. Let's go in, let's do some acupuncture, and let's hang out. And so we quickly became friends, and here we are. It's like the perfect health bridge story, East meets West. Great to see you.
It's great to be here.
Yeah, so look, we've gone way back. I mean, we hike now, we do all kinds of things, but let's go back to our meeting, because I was just this this new guy in town, and I was an acupuncturist, and you wanted to check out what it was that I did, and you heard about acupuncture, but it was different, right? It was different.
Well, I knew very little. I knew very little about it, but I was having a problem with both my shoulders. It wasn't responding to conventional treatment, and the feeling was there's got to be something else out there. And I've always been open to different treatments, but it was time to start discovering the treatments for myself and figure out where do they fit into my treatment algorithm for that problem. And if I didn't try it on myself, then how could I, in clear conscience, ask a patient to go through it?
Good man.
So that's where we started.
Good man. Yeah, we started with me poking needles, and gone back and he's taking care of my whole family. So yes,
I'm honored to do so.
Oh, it's really, really, really been great. Let's kind of set the stage a little bit and just get into your training and your background a little bit, just so we kind of know who this gentleman is beyond this, because you are now one of the most advanced front runner thinkers in my mind on this space of functional orthopedics, which most people don't even know what is. So how'd you get here? Like, what was your traditional training?
Well, I started out, one of the reasons I went into orthopedics is because I was an athlete, and not good enough to compete at the collegiate level, but still liking to do it. When I finished college, I went and got a master's in anatomy at Jefferson Medical College, and then from there went to medical school. And then my plan when I graduated from medical school was that I was going to be double boarded in internal medicine and general surgery. There had been a handful of people in the country that had done that, and I thought I should be the next one. Foolish thinking. I wasn't for me, and I really, the whole idea of I was not treating function. I was treating physiology, and I love doing technical things with my hands, but I wasn't treating functional issues, people's disability or inability to do something that they wanted to do. And that was orthopedics for me. So doing musculoskeletal medicine and the surgical aspect of that, that's how I got into orthopedics. And then my love of sports got me, I went full circle and got into sports medicine. So after I finished my residency in orthopedics, I then did 2 fellowships in sports medicine, one in Boston where I took care of the Red Sox and the Harvard teams. And then I came out to Los Angeles and I worked at the Curl and Jobe Clinic for a while, and then set up practice in Orange County, and here I am getting needles stuck in my shoulders trying to figure out what my next step is.
So Curl and Jobe, for anyone who doesn't know, handled the Lakers and just a bunch of the LA teams.
And at the time, they did all the professional teams in LA. The Lakers, the Rams, the Kings. They did everybody. The Dodgers, the Angels.
And you were there with the founding fathers. You were with Curl and Jobe.
Yes.
Yeah. Curl and Jobe. Yeah. So that's actually the only real orthopedic surgery I've ever had was Dr. Jobe on my shoulder or my elbow. And it was when the MRI was getting popular. So okay, so you did that. Then you were down in Orange County, and I know you guys deal with lots of famous athletes and all that. We're going to name drop, and you started to see something, and you started to kind of trend in a particular direction because yes, injuries can happen, but if my shoulder is, say, front forward or doing something weird, and I keep throwing a football, of course I'm going to hurt myself. So how did you start to shift into this thinking about kind of proper alignment and how we can set up the body and kind of set it up for success versus failure?
Well, it actually started with diving because when I was in my fellowship, I started looking into competitive diving injuries. And when I started in practice, I contacted Sammy Lee. And Sammy was a two-time Olympic gold medal winner in platform diving, who was an ear, nose, and throat surgeon, practiced in Orange County. And I contacted Sammy and said, you know, I'm the guy that sent out this questionnaire, and I wanted to follow up on it. And he said, you don't want to talk to me. You want to talk to Ron O'Brien. He's Greg Louganis' coach down at Mission Viejo. And Sammy had been Greg's coach at the Olympics when he was 16 years old, and then passed him on to Ronnie. So I went down called Ronnie and said, you know, I'd be happy to take care of your divers. I don't know much about the sport, but if you and your divers are willing to teach me, then I'm willing to learn, and I'll just take care of your divers. If I get paid, I get paid. If I don't, I don't. So part of my practice when I started was to go down to the pool at Mission Viejo and sit with the Olympic coach, who was considered one of the best coaches of all time, for 3 or 4 hours at a time, and learn the mechanics of diving. And at times actually there's an underwater window. You could watch what's happening underwater. And I was fascinated by what divers were doing underwater, because they could change the way they entered the water based on what they did underwater with their arms and legs. So it was all pretty cool. So when I started seeing specific injuries, it was like, well, all right, what is it about this sport that's causing these injuries to happen? And what is it about these athletes in particular that were having those problems? And I just started looking at mechanics. And I started looking at the position of the diver's shoulders as they hit the water, and not looking at them from the front, which is where orthopedists always look at their patients. You're facing the patient during the exam. So you figure out what's going on in the front, but I wanted to see what was going on from the back, and their shoulder blades weren't moving properly. And in seeing that, I could say, okay, what is that doing to the rest of the shoulder joint? And then one thing just led to another. So it became a matter of looking at how do things function, and how do those functional problems create structural abnormalities? Why do rotator cuffs tear? Why do shoulders become unstable? Most of the time because the mechanics are off. Sometimes it's a one-time injury, but most of the time it's usually because of a functional problem, because muscles are too short, muscles are not functioning in the right sequence, the brain's not connected well to the muscle, and so it becomes a rehabilitation issue. So it's not a great way to make a living as an orthopedic surgeon, to spend a half hour to 45 minutes analyzing how somebody's shoulder moves, but it's in the best interest of the patient. And if you can keep them out of the operating room, that's okay. You'll eventually see enough patients, and you know, we're all feeding our families pretty well. We're doing okay. So.
That's a point that, I mean, so you were in my first movie, Vitality, and you know, we've all got our opinions about the healthcare system, but there is a financial disincentive to not to take care of the patient that way, obviously, right? You get X amount of dollars, probably 10X that amount of dollars to do a surgery versus, you know, the consult. And you know, a lot of doctors just want to do the procedures that they're trained in. I mean, I don't think there's too many ethical breaches happening in this space. There's just, it's the way it is. It's like, I'm a surgeon, you're coming to me, you're going to get a surgical consult. So you had to kind of cross over and become a functional person. And so you have a very special relationship with physical therapists, and one of the rare ones I've seen for an orthopedic surgeon, because you're just in there with the physical therapists, really consulting on the scaption and the movement and all this, because you see the value of it, and you see the value of, you know, kind of the functional therapy that goes into that. Did that come kind of later, or did you finally realize that you needed good therapists to work with?
Well, during my fellowships, during both of them, I spent a lot of time with athletic trainers and physical therapists, because if somebody had surgery, and I've worked with some incredibly gifted surgeons, but then after the surgery, you're done in an hour or two, and then you turn the patient over to the physical therapist, and they're spending hours a week trying to rehabilitate the patient. And it clearly can't be only the fact that you've restored the anatomy. You still have to restore the physiology, the biomechanics, what we call the sensory motor functions. So, I mean, I always saw the value in that. I mean, I finished and when I was in my fellowship in Boston during the football season, I finished every day in the Harvard training room. So I would see every athlete that had an injury every day and watch their injury from day to day, know what the therapist was doing, what the trainer was doing, and got to see their recovery and got to see the actual effect of what they were doing. So it was pretty easy for me to make that transition. The difficult thing is that we're trained to fix things. I mean, I spent basically 5 years of my life learning how to be an orthopedic surgeon and learning I think as a physician you get chosen. I don't think you decide one day I'm going to be a doctor. I think it's just a special choice that is made for you. And then you are given some skills, technically, and then your job is to culture those skills and make them as good as you possibly can. That becomes your moral and ethical responsibility to get really good at doing it and take all the skills that you've been given and use them properly. When that happens, then it all just fits together. But you spend 5 years of your life learning how to fix something, and then you come out and you go, okay, let me fix stuff. And then you do it, and you start realizing everybody, with all the people that you fixed, not everybody's doing great. Well, what's the difference? Some people are committed, some people aren't. Some people will rehab, some people won't. And you start looking at, if you're critical about what you do, and your upbringing is one of nothing is acceptable other than perfection, then when you start seeing people who aren't doing as well as you would like them to do, then some physicians will turn to the patient and say, well, what did you do wrong? And I'll look inside and say, what do I have to do differently? How do I have to treat this patient differently to get them a better result? I mean, especially when, I was blessed to be given Olympic athletes my first year in practice because nobody else was taking care of divers. So when you're starting at that level, you better have your A game going every time you see them, and especially every time you go to the operating room.
Especially when there's such a strong incentive to get them back on that diving board doing what they're supposed to be doing. So any day down is a bad day. It's like a race car getting stuck in the pit, right?
Yeah.
Yeah, and there's a lot, this person has worked so hard to get to that moment. So it's like, let me back in, let me back in. There's a couple pieces here that I think kind of our listeners or viewers should see, and maybe I'll even call in some graphics for this, is, so when you talk about the scapulae, which are on the back, please talk about how they're connected to the shoulder and all of it. Because I don't think most people think, okay, well, this is my shoulder, right? But the movement and the function of the shoulder is very much predicated on the scapulae. And what's happening is, okay, so I'm not an Olympic diver, and I can very easily sit in front of a desk for 12 hours a day and start doing this. And then you start to see all that weekend warrior stuff because my scapulae live in a different place. So I'd love to tease this out a little bit with shoulders and knees, because I know those are your specialties, and this is where we're all getting beat up.
Well, posture is a pretty important thing to me because we basically, sitting is a disease at this point. There are so many physical, there are so many physiologic things. There's so much relationship now between posture and metabolic syndrome, with diabetes and hypertension and obesity. But I think the easiest way to think about the shoulder and the scapulae or shoulder blades is traditionally the people look at the ball, and it's a big ball in a shallow socket, the shoulder joint. And so people think that it's more like the hip, where it's a ball in a deep socket. It's not. It's really the way a basketball would fit against a saucer. So it's congruent. The curve matches, but it's not deep within it, which is great because then you can swing your arm all the way around your head and you have all this mobility. The price of the mobility is the lack of stability because the socket isn't deep enough. And the socket faces forward by about 30 degrees. So there's a tendency for the ball to be going forward in the socket anyway. So now you take this poor posture where somebody's slumped forward and their shoulder blade is tilted forward and rotated in, and it's also up a little bit. And now all of a sudden the ball gets to slide downhill, puts the rotator cuff under more tension, it pinches the rotator cuff, and it's just a bad deal. The ball and socket joint is classically described by orthopedic surgeons as a golf ball sitting on a tee. And that's great if nothing's moving, because it is like a golf ball sitting on a tee, and instability is if you chip the edge off of the tee, then clearly the ball is going to keep falling off. But it really works more like a sea lion balancing a ball on its nose. It's not a seal that balances the ball at the marine land. It's a sea lion. And wherever the sea lion's nose goes, that's where the ball's going to go. Well, that's your shoulder blade. And the sea lion's nose represents the socket. And the ball, which is the humeral head, represents the ball. And the ball is going to go wherever the socket goes. So if you're out of position, then it can't function properly. So what happens is all the muscles in the back get very stretched out and very weak. And all the muscles in the front get too tight and they get pulled down. So if you have a kid that sits playing video games hunched over like this, or he's doing his homework, or he's got his laptop, he's never upright. So there's no reason for the structures in the front not to get too tight. So when I see, and it's very common in athletes, even elite athletes. I mean, next time you watch a diving meet, mainly swimmers, more so than divers, watch them walk on the pool deck. They look like apes. They're just hanging down. And the therapists, some of the therapists that I work with young boys, will tease them and say, "You got to make a decision. Do you want to be a monkey, or do you want to be a man? You know, stand up like a man."
Is it again just because of all the like desk time and all these things that are happening?
Yeah.
And that relates to all of us, obviously, right? Like even with
Absolutely.
elite athletes, it's like I get on a plane and go to that other part of the country or world, and they're just in that kind of slouchy position. And so
Well, it's very natural. Everything we do is sitting. So I try to motivate my patients to get up and move around. I mean, the new Apple Watch tells you got to get up.
Yeah,
it has a
absolutely.
little alarm and tells you to get up. So,
Yeah. So, okay, so just to kind of illustrate this a little more, if my scapulae are up and out, I'm going to over-exaggerate this, my shoulder's not in position. So now every time I come to raise it, I lack the mobility and it's kind of out of the socket. So now I'm going to try to do something crazy like lift some weights or swing a baseball bat. It's not positioned correctly biomechanically to be able to kind of stay in that socket because it's such a loose...
well, it's still within the socket, but it's not being centered within the socket. So if we just do something very simple now, just go ahead and slouch, okay? And just take your right arm and lift it up as far as you can. And you get to a point that you can't lift it anymore. Okay, so now bring it down, and now just lift your chest. And now bring your arm, and now lift it.
Untuck my shirt a little. There it is. Yeah.
You now have more clearance. So the reason that you stopped here is because the acromion, which is the tip of the shoulder blade, is tilted down. And what's happening is when you bring your arm up, the bursa, which is a little lubricating sac, and the rotator cuff are hitting underneath that bone, and it physically can't get there. And it gets pretty uncomfortable if you're doing it. And all you've got to do, I don't cue patients by telling them pull your shoulder blades back and down. Ultimately, that's where I want them to be. But instead of thinking back there, I just want them thinking right here. So just lift your chest.
Chest up.
And as soon as you lift your chest, your shoulder blades just drop. They tilt back, they rotate down.
Great.
And they're in position. So what I tell patients is, and anybody I see with a shoulder problem, I mean, if I think there's a postural component to it, and sometimes even if I don't, what I tell them to do is when you're sitting and driving, keep your chest facing your windshield, not your pedals. And they're going to forget that. But in Southern California, as much as we stop and go, every time you come to a stop, put a Post-it somewhere on your dashboard. Every time you come to a stop, just lift your chest. And then you'll sit there at the light, you'll listen to the music, you'll phase out, and then you're back down. So when we talk to patients about doing exercises and we say, I want you to do this program, and they say, well, I don't have time. Well, you have a minute 60 times a day, and you got an hour of this, and you're stretching the front, and you're pulling the back down. And the other thing is I tell them, we're taught to drive with our hands at 10 and 2, which is not a good position. Your upper trapezius fires and pulls your shoulder forward. If you look at the hands of race car drivers on the cameras that are in the cars, they're at 3 and 9, and you can drive at 4 and 8 and still have good control of your wheel. So I tell my patients, just if you do that, it's hard to slouch when your hands are at 4 and 8.
I love that.
So I think it's very helpful to give patients, my job as I see it in the office is to educate people. I'm a teacher. My job is to give them information so that they can figure out what's the next step for them. How do they take care of themselves? Because I can't be with them all the time. Therapists can't be with them all the time. Right. So when I refer somebody for therapy, part of that is the therapist is like your golf pro. The therapist will check your swing, make sure you're doing it properly, and then you go to the driving range and do the work. Therapist isn't going to be with you. An hour of therapy twice a week is not going to cover all the hours that you're sitting like that.
And that's a cultural thing too, right? It's like they come to you and they say, fix me. They go to a therapist and say, fix me, versus getting out there and practicing their swing, getting out there and doing it. And that's, I mean, we've all been kind of moved into that area. So there's another piece to this that also is remarkably more on the postural side, oftentimes than not, and it's the knees. And you see it a lot. But you know, when people's hips aren't working correctly and all this, everyone's like, hey, you know what? I decided I've gained 30 pounds. I'm going to go run a marathon next week, and they're functionally just not aligned. So can we talk about how the knees and the hips and biomechanics work?
Sure. Well, the knees are basically controlled by the hips. So when we look at, earlier you mentioned alignment, and we were talking about diver's alignment, but there's an alignment in the lower body as well. And so the Czechoslovakians were incredible with the basic science about this, and what was called the upper cross syndrome for the shoulders and lower cross syndrome for the lower body. But if you think about it, the bones in the knee are the kneecap, the shin bone or tibia, the femur or thigh bone, and a little fibula on the side, which doesn't have much to do with this. But the knee joint itself is the femur and the tibia. And the other end of the femur is the hip. So the rotation of the femur is going to be determined by the muscle interactions around the hip. And if you have, again, going back to exactly what we talked about with the shoulder, tightness in the front, weakness in the back, from sitting, the muscles in the front get tight. The muscles around the back get weak. So if you take a high-level athlete who's having a knee problem, first test I do is I have them stand on one leg, the opposite leg, just to see how can they control their core. And you take a really elite athlete, they stand on one leg, and all of a sudden their pelvis is starting to tilt. And then you say, stay right where you are, and I want you to do a very, very slow half squat. And they start to come down, and the knee starts to drop in. Because of the weakness of the muscles that externally rotate or rotate the hip out. And so most of the problems that I see in knees, especially young teenage girls, is kneecap not tracking properly. And the reason for that is, just as we were talking about alignment in the shoulder, if this is the groove that the kneecap sits in, then if the femur is rotating in, then the kneecap is going out. So for years we did surgery on kids' kneecaps that, to try to realign them, and it's just like, just put them in therapy. And interestingly, I mean, there's an epidemic now of anterior cruciate ligament tears. We were just talking about that earlier. And the only thing that's been associated with ACL tears is hip weakness in female soccer players at the high school and collegiate level.
Wow. Is there a reason why because you mentioned female athletes a couple times here, is it just the way their hips are aligned, or is it we're just seeing a more proclivity of it?
I think it's, there's been so much research on this to see if it's their anatomy, if it's their physiology. We've looked at menstrual periods and the association between menstrual periods and ACL tears. And the only thing that's consistent is the weakness around the hip. It's not the angle, to some extent it may be because of the angle of the hips, because a girl's pelvis is wider than a man's. But that's all part of the alignment thing.
So strong hips that are functional, move correctly, will ideally get the kneecaps to track correctly, which means when you're trying to put in the miles, you're not wearing it down.
Exactly. The analogy that I use with patients is, if the front end of your car is out of alignment, you're going to wear out your tires. I try to give analogies that people can identify with. For kneecap tracking, it's very easy when I'm showing somebody an x-ray of the kneecap sitting in its groove, and I say, well, when I had you standing, I did this. But when I'm showing them that, what I say is, think about the kneecap as a train on a track. You got two issues here. Are there structures that are too tight that are pulling the kneecap over? So it's pulling the train off the track. And in your case, what we found on exam was, yes, that was the case, or no. But the other thing is, sometimes there's a little switchman up here that's shutting off the muscles, that's derailing the train by moving the track. So if your femur is rotating in, the track is moving, and the kneecap can't stay in the track.
So when we're tight in the hips, we tend to internally rotate the femur, right? If your femur's rotating in, what you're saying is we want the muscles that externally rotate the hips to get worked, to get stronger. In particular, there's like specific exercises that are just kind of universal. Is it way too case dependent?
Well, it's primarily the gluteus medius muscle. Okay. It's a rather large muscle as opposed to the gluteus maximus, which is the tush that everybody knows about. There are general exercises that can be done, but that's a little bit like, going back to the golf pro analogy, that's a little like giving somebody a book and saying, here, learn how to play golf. You know, you really want somebody who's skilled at diagnosing that, a good physical therapist. And that's not in the realm of an orthopedic surgeon. I mean, I don't want to be teaching exercises to my patients. If they tell me what they're doing, I'll just tell them that either is or not what we want you to do, but I don't want to be spending office hours trying to demonstrate exercises. So, but it gets pretty specific. And the big thing that I see is when people are rehabbed for their hips and knees, is some physical therapists who are not very sophisticated will work in one plane. So you see people, I'm sure when you go to the gym, you see people doing lunges, and they're walking doing lunges, and they're doing weights, and they're lifting their legs, but it doesn't do anything for rotation. So now take that athlete and say, yeah, but you're not going to run straight ahead. You're going to plant your foot and you're going to cut. Well, how do you control your femur? And if your femur is not being controlled and your ACL is attaching to it, that could not be a happy ending sometimes.
So multi-directional functional movement is a big piece of this.
Yeah, we call it multiplanar, but multi-directional is. So, I mean, you have some, if I have an athlete, you know, that I just want to get into his head a little bit. First of all, I like demonstrating, I don't only see athletes, but demonstrating to an athlete who thinks, hey, I got this, how weak they can be is ideal. Because then, you know, and there are specific tests that we do when I'm evaluating somebody's shoulder. I mean, what I just did with you, you know, we can change your range of motion just by putting your chest up. Yep. I can do the same thing with somebody's rotator cuff and show, look how weak you are. Especially, I love doing this with swimmers, because swimmers, you know, they're putting in, 20, sometimes between 10 and 20,000 yards a day, depending on how elite they are. And it's like, well, why would I want to do more strengthening? You know, what does my posture have to do with this? And I can show them, you know, let me just do a little test here. And I show them how weak their rotator cuff is. Just lift your chest. Lift the chest, test their rotator cuff strength against specific muscles. Now it's stronger. You go, okay, so now let's think this out. If I can change your strength in 2 seconds by having you lift your chest, what happens to your times in the pool if you keep your chest lifted while you're swimming?
You want to win, right?
Now all of a sudden you got him. That's my hook with athletes. So I think it's important to individualize things and try to find the hook for that athlete. There are some kids that, you know, the more you point things out, the more upset they get with you and the more they don't want to listen to you. So it's, you know, there's a lot of psychology involved in taking care of athletes.
Okay, so it's true.
I mean, taking care of anybody.
Yeah, and they got there because they were that kind of pointed and directed anyways, right? So now you're getting in the way of their day. Yep. So when for surgery? Because obviously surgeries happen. Things tear, bad things happen. At what point for you is there an indication? I mean, there's obviously clear indications when things get torn off, but there's a lot of things that are in that gray area as well.
Yeah. I almost always let the patient decide. I mean, I'm not doing cancer surgery. I'm doing things to allow people to function at a higher level, whatever that is. But I think it's up to the patient to decide, is their level of function acceptable or not? So what I tell them is, my indication for surgery is when the problem that you have is no longer consistent with your lifestyle, and you can't or won't change your lifestyle. That's pretty straightforward. So if your knee bothers you when you play singles tennis, but it doesn't bother you if you play doubles and you don't have to cover the whole court, and you don't care whether you play singles or not, play doubles and don't have surgery on your knee. I mean, if I don't want to allow, I've got to differentiate for the patient, are they just playing in pain, or are they playing with a chance of getting more injured? I don't want somebody playing with a chance of getting more injured. My job is to educate them about that. But if it's just pain, I mean, crap, any of us who have been athletes played with pain. I mean, as I get older, I'm living with pain.
Anyone over 30 knows pain.
Exactly right. So it's just a matter, you fit it in with their lifestyle. I mean, there are times that I operated on a young man today who, and this makes me feel old because he's now in his mid-40s. He was a member of the national diving team, and I took care of him when he was a member of the national diving team and diving at a very elite level. And we just rehabbed his shoulders. And he came in about 6 months ago and he said, there's something wrong with my shoulders and it's beyond what we've had before. Well, he's got torn rotator cuffs now, small tears, and they're very fixable. It's like, well, you want to rehab it or you want to get it fixed? He goes, no, I know my body. These aren't fixing themselves. So this morning we did the first one, and probably in 3 months we'll do the second.
Mm-hmm. When you've done a surgery, because a lot of people go for surgery and think like, hallelujah, they wave the wand over me, now it's going to be better. How much personal involvement needs to be there when we start looking at rehab, when we start looking at diet, when we start looking at all the things that go into us being your partner in this surgery as a patient?
Yeah. I think you picked the right word, because I use the word partner with my patients, that we're partners in this. This is not, I'm going to fix you. I am going to set you up to be fixed. I will do my job in the operating room, and I tell them a good result depends on making the right diagnosis, doing the right operation, and doing it well. I said, I got you there. I'm okay with my skill set. Mm-hmm. But if you don't rehab it, or you don't do the right rehab, you can't do well. So are you in or are you not? And I mean, I don't operate on everybody I see that needs surgery. I have no problem telling a patient that I don't think I'm the right surgeon for you. Mm-hmm. And I don't mean to offend them that way, and it's not a matter of arrogance, it's a matter of, I'm result driven. I mean,
you make me look bad.
Yeah, that's it. And I actually tease about that. I say, look, everything in life is all about me. It's got nothing to do with you. And if you make me look bad, and I'm cranky when I go home, there's just not enough energy for when I get home to my wife. And I live my life for my wife. So,
so it's actually not about you, it's about your wife.
Well, no, it's about my ultimate happiness.
Right. Happy wife, happy life. Right. So, there's been a lot of kind of noise in the channel with healthcare reform and all sorts of things. But at the end of the day, I own this body, I got to take care of it. Like either I stretched before I went for the basketball game or I didn't, right? And so you get a lot of people that come in, weekend warriors, that are just like, I decided I'm going to get fit, and they don't align their hips with their knees. Like no one wants to take the time, right? No one wants to stretch, no one wants to take the time. Then they hurt themselves. Then you have doctors that'll just happily do the surgery, and then they go back for a second surgery, third surgery, all that. So you're in this kind of interesting arc of your career now, where you've been at the height and you've been at the top of your game for a long time, and now looking out at the horizon of like how you would like orthopedics to kind of grow with this kind of functional medicine movement and all these things that we've learned now. How would a patient out there want to talk to their doctor? How do we prepare everyone out there who's out there banging their knees and their joints and all this?
Yeah, that's a really complex question.
It is.
Because there were multiple levels to what you're asking. First of all, medicine has changed, and this is nothing political. There is less time for your doctor to spend with you. For the reimbursement that the doctor is getting, it's not necessarily reasonable for him to be able to sit and chat with you for a half hour or 45 minutes. So I would like a patient to come in ready to discuss the problem. I mean, they're very simple things. We ask our patients, go to the website and fill out your forms before you come in. I mean, if you've got an 8 o'clock appointment and you show up at 10 after 8 and you haven't done your forms and you're not done until 8:45, it screws up my day. And I can't, as much as I want to give you all the time you need, it's really not very easy to do that.
You're digging into someone else's time.
Well, it's a matter of being respectful. Mm-hmm. And I think that what's happened now is so many assumptions have been made, and the insurance companies have gotten between patients and physicians, and we're not partners anymore. So part of it is, for me, just letting my patients know I respect them. I mean, look, I just have a different skill set than they do. The guy that works doing assembly work, I mean, I'm no better than he is. I just happen to have different skills. I happen to be more educated. So I would never want him to think he can ask me a question. And I think part of it is make sure that patients ask questions, but come prepared. Part of the problem is, as you and I were discussing earlier, I have a mug that I use in the office that says, please don't confuse your Google search with my medical degree. And, because patients come with reams of paper and they go, well, what about this guy's opinion? What about that guy's opinion? I'll give you mine. And I treat them with kindness and caring. And I, in general, there's a match. So I think that if we're efficient with our time, I think we can do it. A lot of the information I give patients, it's like, here are the cliff notes. Here's what you've got. Here's what we need to do. Here's my rationale for doing that. And then what you need to do is go to my website, and there I have PDFs. There's a PDF on lifestyle changes for people with inflammatory problems. I mean, there's a whole thing about which I learned from you, diet and exercise and sleep and mindset. And if you sleep well, your arthritis is better, your inflammatory condition is better. I have patients, we talk about supplements and what supplements they should be taking. I mean, I take turmeric on a regular basis. It's a great anti-inflammatory, and it's sort of a freebie. Not much in the way of side effects. So part of it, I think, is if we demonstrate any arrogance whatsoever in dealing with our patient, then they have no reason not to hold us accountable for making them better. Because we've implied, if you listen to me, you'll be better. Well, that's crap. I'll teach you how to help take care. I'll help you learn how to take care of yourself, but that's not my body. I got enough trouble taking care of my body and my family's bodies. I'll help you. I'll give you the information that you need, and then if questions come up, I'll take you through that. But I think part of that is how the patient is approached. And I'm not implying for a minute that there are a bunch of arrogant physicians running around out there, but when you get busy, it sometimes becomes hard to put yourself in the patient's place, because nobody wants to go to the doctor. Nobody wants to be injured. I mean, despite what my mother said to me growing up, people don't want to necessarily meet me, especially as a physician. So, we see people at their worst. I mean, so I'm going to give anybody the benefit of the doubt when I'm seeing them. And the thing, I actually, when I go into a patient room, when my hand touches the doorknob, the last word in my mind is kindness.
Is this your mantra?
That's it. Because there are people, there are some unhappy, I have unhappy days as well. I hope that I don't take it out on the people around me, but there are people who, if they had trouble getting a spot in our parking structure, I mean, our office is huge. If they had, then their need at that point is to talk about the parking structure. Okay, I'll give you 15, 20 seconds on that, but you know what? Let's not let that get in the way of your care.
Right. Let's get back on your shoulder.
That's important to me, and I'll make sure that we take that into consideration as we're doing our planning, but let's talk about why you're here. And I try never to, I don't always succeed, but I try to make people think everything that they're saying is important. I can't listen to everything they have to say. There was an interesting study done at my medical school after I graduated. My school was the first school that actually had one-way glass. And they would videotape students interviewing actors who were patients, and then they would go back around the glass, and the professor would sit with them and say, here's what you did right, here's what you did wrong. And they did a study where patients came in and they said, and they were asked their initial question, like, what brings you in today? And they timed, how long did it take for the physician to interrupt the patient? 18 seconds was the average. The average. So, I mean, when I lecture, I quote William Lister, who's a physician from the 1800s. If you listen to the patient, he will tell you his diagnosis. Just listen, damn it. And just ask. You have to ask pointed questions, and I do that with the questionnaires that I ask them to complete before they come in. And I'll go over it with them, and I tell them, page 1 is how did we get here? How did it start? What was your treatment? Page 2 is, all right, you're done with all that. Where are we now? What are your current symptoms? What works? What doesn't work? What's been tried? And then I usually With shoulders, I'm probably about 90% of my diagnoses I make based on the history. And knees, probably not too far away from that. Patients will tell you, but the feeling now is we don't have time to listen.
Right.
And it makes you much more efficient. If you listen, you don't have to do very much. I mean, so much of my exam, is to make the patient feel that I'm doing everything I possibly can, but I know way before that.
Yeah.
But
at this point, you're kind of holding court.
Yeah, and I do make sure. I'm trying to think now. Pretty much every patient, almost every visit, I touch them.
Yeah.
I mean, what we're hearing now is a lot of people just don't have time. It's how many patients are you seeing in a half a day, and you just have to get it done. So, your knee hurts, we got x-rays, you've got arthritis, you need a joint replacement. I actually, a couple of years ago, I had a woman that came in and clearly needed a hip replacement from the history. And I said, well, go ahead and lie down on the table. She said, what are you doing? And I said, I'm examining you. She said, why are you doing that? The other doctor just looked at the x-ray. And I said, because how will I know how your hip is moving if I don't touch it? Okay.
Wow.
So,
and that's an interesting kind of swing in the pendulum, right? Because with radiology and all these kind of like diagnostics, we use the data to make data-driven decisions, but we've lost that personal touch. We've lost the assessment and all these things that actually, way before the MRI, that's all we had.
Right.
Yeah. Yeah.
And it's still very useful. So, you can see structure on images, X-ray and CAT scan and MRI. You can't see function. You don't know how it's working. So you take an X-ray of the shoulder and you go, yeah, okay, the ball and socket joint are fine, and you don't have impingement. Now, what's your diagnosis? Yeah. So so much of my exam is functional because ultimately, what do we want to do? Restore function.
And then once function is there, you're less likely to get injured. You live healthier, you're able to do the exercise, you drop the weight, everything starts working out way better when your body's doing what it's supposed to do.
Right.
Yeah, I love it. I love everything that you're doing. I love you, I love your work. How can people find you and get just more educated on this kind of functional orthopedic gestalt that you're speaking?
A lot of it's on my website. There on the website are a number of lectures that I've given to physicians and physical therapists, so it's maybe a little bit more sophisticated than lay people would want. But it's interesting how many patients I've had that have come in and said, I watched your lectures and I think I know what's wrong. So it's kind of, so I've succeeded in teaching. So I mean, my website is benrubinmd.com, and
love it. You're a gentleman, a scholar, and a good friend. Thank you.
It's my pleasure.
Yep.
Thanks.